Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Dr McLean. I'm a respiratory physician at Royal Prince Alfred Hospital in Sydney, and I'm also currently a PhD student with the University of Sydney and also the Wilcox Centre for Lung Cancer Research, completing my PhD in the area of lung cancer and the microbiome. Before we start the podcast, I think it's important that we, the Thoracic Oncology Group of Australasia, acknowledge the traditional custodians of the land on which we live and work. We pay our respect to their elders past, present and emerging, and we also extend that respect to all Indigenous people. In today's episode, we're exploring an exciting area, an emerging area, which is the microbiome and its role in lung cancer. In particular, the potential of the microbiome in influencing lung cancer treatment, which we know has a long way to go in terms of optimizing outcomes, and also looking at immune-related adverse reactions. While today's podcast doesn't have a specific sponsor, we'd like to thank all the donors who have contributed directly to TOGA and fundraising events that enable TOGA to directly support research through the Inspirational Research Grants. TOGA has funded 2 projects focused on the microbiome in lung cancer, and we're very lucky on today's show to have both Inspirational Research Grant recipients, being Sagun Parakh, who's a medical oncologist at the Austin Hospital and research fellow at the Olivia Newton-John Cancer Research Institute, and Mark Adams, who's a senior research fellow at Queensland University of Technology. So welcome, Mark. Welcome, Sagun. Thank you for being here today.
Thanks, Anna.
Yeah, thanks for having us.
So I think the best way to start this podcast off, the microbiome is obviously an emerging area that perhaps not all of our listeners have familiarity with. So starting with you, Mark, if you don't mind probably answering the hardest question of today, which is, what is the microbiome? How do we define it? And sort of what are the different ways that we can break it down?
Yeah, absolutely. Yeah, thanks very much, Anna. So I think the microbiome has really grown in excitement in the last couple of years, and we're learning more and more about what the microbiome is. So what we really think the microbiome is, and what it actually is, is that it's a diverse community of bacteria, archaea, fungi, protists, and viruses. So the whole community of these different organisms, and they exist on our human body and within our human body, and certainly the abundances of those various microbiota change across the varying sites in the body. So of course we're on this podcast very interested in the lung microbiome, but certainly a lot of what we know about the microbiome comes from the gut and the gastrointestinal tract, and there's a great what we call biomass within that organ. And there's a lot of knowledge that we've gained over the last certainly 100 years that these microbiomes exist to impact human health. So we know that there's commensal microorganisms. So these particular microorganisms don't induce any pathogenesis, and they exist naturally in our body, and they have a lot of health benefits. So for example, they exist in the first line of defense against pathogens. They really help our body to metabolize different nutrients, and some of those nutrients themselves and the metabolites produced by these various species and microbiota, there to influence the function of our human cells. And so that, of course, has key roles in training and controlling some of the immune system and how our bodies respond to pathogens.
And as you mentioned, most of the research to date seems to be focused on the gut microbiome because that's where, the biggest biomass is. What do we know about sort of how the gut microbiome and the lung microbiome are related? Are they functioning independently? Are they working together? Is the lung microbiome relevant at all?
Yeah, good question, Anna. Look, short answer is yes, the lung microbiome is immensely relevant. But we do know that from research, and certainly with other disease states, that the gut microbiome can influence how our body responds to various different diseases. So a lot in terms of solid cancers, there's a lot of research that's been performed predominantly in the melanoma space to show that gut microbiome can influence how patients respond, or that patients' tumors, shall I say, respond to treatment. But bringing it back to the topic of the podcast when it comes to the lung, certainly years ago, the lung was considered to be a sterile environment. But we now know from our growing research that there's a whole vast array of species and microbiota that exist in the lung. And certainly when it comes to lung cancer, some of those species can or have been shown to be dysregulated. So that's a particular term called dysbiosis. So there's a change in the abundance of certain microorganisms that exist in a disease state that may contribute to the disease state as well. So certainly, and that when it comes to our grant, we believe that the lung is, and understanding the different microbiota within the lung is really important.
Yeah, so I think we'll come to the interesting aspect of sort of trying to measure such a low biomass system as the lung microbiome, which I think is a big part of your grant. But maybe, Sagan, because I haven't introduced you yet into the conversation, what do we know so far about the microbiome, I guess both the gut microbiome and the lung microbiome, which we're focusing more on in this podcast, and its effect on lung cancer risk? Is there any data so far correlating dysbiosis or an abnormal microbiome and your risk of lung cancer?
So yeah, I guess we do know that the chronic inflammatory diseases, COPD, emphysema can cause dysbiosis, and then this sort of predisposes to inflammatory changes, which can lead obviously to lung cancer. From my reading and understanding, I don't think that association's been established as such about the development of lung cancer and the role of the microbiome, but obviously it does cause chronic inflammation, which we do know can lead to epithelial changes and therefore sort of development of lung cancer. I think from a oncologist point of view, even though the microbiome's been around for 100 years, I think sort of just with the advent of immunotherapy, sort of when our sort of attention went to the microbiome, and so as Mark's already said and you've already alluded to, sort of the gut was the focus, and I think the next step is obviously the lung now.
Yeah, it is very interesting. I think there are few studies that have looked so far at the lung microbiome and dysbiosis and how that might lead to downstream pathways leading to carcinogenesis and then even sort of progression of lung cancer. And I think part of the reason there are such few studies is the difficulty in quantifying and measuring the lung microbiome. I think this is a big part of your grant, Mark. Do you want to speak to the issues we have in collecting, analysing, and then assessing lung microbiome and thoracic cancers, I guess, specifically?
Yeah, certainly. So just to let the listeners know, there's a couple of approaches that we can use to study the microbiome, and they're very genetic based. So we can sequence to identify the particular microbiota that exists within that site that's been collected. So just to summarize those two particular methods, there's 16S rRNA sequencing and there's metagenomic shotgun sequencing. So these are the two methods. Now, there's a lot of pros and cons with both methods, and most prominently, I think, in the literature that 16S rRNA sequencing has been employed. Certainly, just to let you know that with the recent TOGA funding, we're looking to do is to employ metagenomic shotgun sequencing. Now, the difference between those two, I mentioned as pros and cons, that R16S sequencing that focuses on amplifying and sequencing the variable regions within the microbiota themselves. So then that's really enables us to detect and identify bacteria and archaea predominantly, but only at the taxa, at the genus and species level. But it lacks a lot of functional insight. Now, when it comes to the metagenomic sequencing, this is capable of analysing all the microbiome elements that exist within that particular sample. So we can look at bacteria, the archaea, the fungi, the viruses as well. It also can provide us with a little bit more functional data. So some of the metabolic pathways that may be impacted by the microbiome themselves. So that's the difference between 16S and the metagenomic shotgun sequencing. Now, when it comes to those two approaches, as a scientist, this is a really important consideration, is the price point. So 16S is a lot cheaper, whereas shotgun sequencing is a lot more expensive and requires some more bioinformatic analysis to enable us to put those genomes back together. But as I mentioned, the shotgun sequencing enables us to identify some of those lower abundance microbiota that might exist. And this is particularly important when we consider using lavage fluid, for example, to identify microbiota within the lung itself and those low biomass samples. Now, a challenge, of course, whilst that's all well and good, is that there is the contamination from the host. So the host genome can get in the way, shall we say. So we do rely on some of those more technical bioinformatic skill sets to be able to untangle the genome from the host and that of the microbiome itself. So at QUT, we have a couple of research laboratories that we're relying on who have developed some bespoke bioinformatic tools to help us do that. So that's the comparison between the detection methods, shall we say.
Yeah, I find that sort of bioinformatic and genetic analysis fascinating. Being a respiratory physician, obviously, it's all very new to me, these different techniques that are required. And I think perhaps one of the reasons why research into the lung microbiome hasn't taken off is a bit of that lack of understanding from many of respiratory physicians, medical oncologists about, how reliable these techniques are and how much stock we can put on the results we find. And also, I think the small data sets I know now there's a big push from many other members of TOGA to try and develop some larger data sets that include bronchial alveolar lavages so that we can get bigger cohorts and then perhaps more reliable results. But currently it seems that we're looking at very small data sets, and with that propensity for contamination or very low biomass samples or species that themselves have a very low relative abundance, it gets tricky to make big conclusions from the data we have. What is your group, Mark, doing in terms of that? Have you managed to collaborate with other research centres or have a way around those sorts of issues?
Yeah, absolutely. So I think collaboration is really the key, isn't it? If we can get samples from a variety of sources, certainly across Australia, we can really increase that sample size for one. That's on the clinical side, but here we are on the scientific side. If we can bring in all these different expertise to enable us to apply some of these more cutting-edge approaches. So yes, we've got some great metagenomic sequencing available across Australia, but the bioinformatic analysis is constantly improving. As I mentioned before, we can really try and delve a little bit deeper into the data that we do have to identify those really low abundant species. And that's what really excites me. I think if we can identify species or a particular microbiota, shall I say, that's not been identified within the lung before, and it's that very minute particular element within the microbiome that is the difference between a disease state versus a non-malignant sample. Can that have some biomarker potential? I think that's the excitement. We might talk about that a little bit later. But absolutely, we can really bring to the table different expertise to help us with that analysis.
Yeah, I think, the microbiome is such an interesting and promising area, looking at the sort of gut microbiome and the results they're getting with fecal microbiota transplant already in small studies. I think if we can pin down the methodology to get reliable results in lung microbiome, we could find some pretty amazing things that have real differences as biomarkers for treatment response in immunotherapy. And so I guess, Sagun, that's one aspect is looking at treatment response, but your research is focusing on another important aspect of immunotherapy, which is the significant risk of adverse events, in particularly different types of sort of autoimmune issues, in particular pneumonitis. As a respiratory physician, we see the issue of pneumonitis immunotherapy quite commonly. It's a very complex area because often these people have had multiple lines of treatment. There might be radiotherapy involved, and it can be quite difficult to detangle what's going on. So if we had some biomarkers that told us who was more or less likely to develop pneumonitis, that could be a real game changer. Where's your research at, and what are you looking at in terms of those areas?
Yeah, you sort of summarized what I'm doing. So yeah, exactly that. We see pneumonitis a lot. I mean, I think the trials sort of all focus on the high grades pneumonitis, but I think we see pneumonitis a lot more commonly, particularly the low grades where you see these radiological changes, but the patient feels well and you don't know whether to start steroids or not, and then do you re-challenge or not. And so obviously, as you know, Mark, and you've sort of mentioned collaboration. So, with the respiratory physicians we have at the Austin, whether we can lavage these patients and try and see whether there's any predisposition based on the microbiome. I think the other aspect as well is most of lung cancer patients are smokers, and the role of concomitant medications, inhalers, steroids, and the impact I guess these have on the microbiome and whether the use predisposes them or not to pneumonitis. So these are sort of the questions the grant is sort of trying to answer. I might also take this opportunity to sort of have a plug-in for the Tracker Biobank and talk sort of about resources and the number of samples that you're talking about. So you're right. So trying to get working as an individual site, I don't think you'll ever get the critical number to answer any of these questions meaningfully. So we're trying to use the Tracker Biobank to try and increase the number of samples that we can get. And I guess this is sort of a national collaboration. So hopefully we can get the numbers for a bioinformatician to sort of tell us whether it's relevant or not. But yeah, so I guess more questions at the minute than answers, to be honest.
Yes, it seems that way, but just being in this space, I guess I'm seeing more and more people sign on to PhDs looking at the microbiome, and the Tracker is an incredibly exciting project. We at RPA have just signed on, and I can see the numbers are building. And I guess the other important thing is with Tracker, there's standard operating procedures. It'll be nice to have consistent methodology to obtain microbiome samples. And also I think Tracker involves a really broad spectrum of samples. So, we're not just getting BALs, they're getting oral swabs, they're getting tissue samples from lymph nodes, they're getting blood. So all these things can sort of provide incredible opportunities to do more detailed research. And I think there's also potential soon to look at, I think the Tracker databases today are focused on advanced disease, but I think, is it true, Sagan, that they're now looking to move into the sort of early lung cancer space as well? We might be seeing samples from early lung cancer.
Yeah, correct. So I think the ethics and the approval is for lung cancer across the board. And I guess just to your question right at the beginning about the development of lung cancer. And so if we can get these early lung cancer specimens and whether it's different from a patient who's got metastatic disease, I think that may tell us a bit about trajectory and who's more prone to developing metastatic disease. With the lung cancer screening program coming on board as well, whether we can identify these patients early and prevent progression, I think would be another exciting sort of area.
Yeah, and I just wonder with immunotherapy sort of moving into that early lung cancer space and the fact that all the sort of gut microbiome trials to date have focused on metastatic disease, whether that's an area where the lung microbiome will be actually very separate to the gut microbiome in that they don't have a systemic condition you're treating a focal lung condition. So I think that would be an interesting area that hasn't really been explored at all, I imagine.
Yeah, correct. Yeah. And how you can sort of modulate the microenvironment to prevent disease, I guess, would be the next sort of logical step, I think.
Yes, and I guess that's also the logical step in the discussion. I guess either Mark or Sagun, what do you think the potential for modulation of the microbiome is? I think in the gut microbiome, obviously, they've looked at fecal transplants and there's had lots of promising research there. There's not been a lot of promise in looking at probiotics to date, I don't think, in terms of off-the-counter stuff. There's some focus on prebiotics and increasing fiber in the diet, but all these sort of interventions seem to focus on the gut. Do you think there'll be any way that we can use interventions in the lung microbiome?
I'm happy to start. Obviously, I'm not a clinician, so I can't speak to the therapeutic angle too much. But you've really hit the key points there, Anna. I think we know, certainly from other species even, within cows, for example, I know there's ongoing work looking at prebiotics because we know bacteria, for example, metabolize these complex carbohydrates. So if we're able to increase the dietary intake for some of these complex carbohydrates, we can feed specific bacterial species to grow their abundance within the gut, for example. But I do wonder if we can do so once we know those specific species that exist either within the gut or in the lung itself. If we have a specific, we know its fuel source, shall we say, we can then feed those beneficial microbiota to improve their abundance and to then impact therapy, most prominently, of course, immunotherapy.
Yeah, no, I think just building on what you said, I mean, we do know that certain species do, say, increase PD-L1 expression, for example. And so whether I don't know how, but whether you increase their numbers in the lung microbiome to see whether that improves the response to immunotherapy. I guess the flip side is whether you increase the risk of toxicity. And so I think those are sort of the balance that you have to sort of meet between toxicity and efficacy, I guess, and the role of the microbiome in that.
Yeah, it's an early space, a fascinating space, I think, for treatment. And I guess as scientists, clinicians on both sides of the lung cancer sort of treatment arc, we know that treatment at the moment is sort of very suboptimal for lung cancer patients. The response rates remain pretty low. So I think the microbiome is an exciting and possibly a less toxic way to modulate people's treatment response. I guess, Sagun, you're sort of early on in the research, I think, looking at pneumonitis. If you had the opportunity to sort of develop any new studies or have access to new data or information, what do you think we sort of need to push this microbiome space along? What are the sort of big breakthroughs or new studies that need to be done?
I think it's all about biomarker discovery, really. And I think we tend to, I think early referrals and early sort of pickup is the key. I think we sort of tend to refer patients after we started them on steroids and then think about, maybe we should refer them for bronchoscopy. Whereas I think anyone with suspicious changes, symptoms should probably be seen earlier in the respiratory clinic. I mean, we're talking about the lavage and the microbiome, but you can also talk about pulmonary function tests and whether that has changes over with pneumonitis and then whether we can use that as a surrogate biomarker. But I think early referral to the respiratory colleagues, trying to get the samples earlier and see whether that makes a difference. I think currently for pneumonitis, whether it's immunotherapy or radiotherapy related, we have an obscure sort of cutoff for CD8 infiltration and whether we sort of try and use the microbiome as to say whether this, one is more in a certain type of pneumonitis. So I think it's just critical mass. The more samples you have, the more we can sort of infer and make deductions, I think. So that's what we're trying to do, trying to collaborate more with the respiratory physician, send more samples, try and get more samples. Yeah.
And Mark, what about you? What are the sort of wish lists that you have for sort of ongoing microbiome research?
Yeah, absolutely. I think Sagan's got the main idea there, and more samples for starters. So more collaboration, I think, is really important. But I really advocate for this sort of discovery research. If we can learn more about some species that we may not have identified before, or various viruses, for example, that might exist in the lung, knowing more is going to empower us in the future. So, as I said, really advocate for that discovery biology, and that's really what this TOGA Inspirational Research Grant enables us to do, is to apply some of this cutting-edge genomic sequencing and bioinformatics tools to help us identify some of those. So, as we move forward, we don't know whether or not these will be novel biomarkers, but there's great potential to be applied.
And I guess being on the sort of cutting edge of microbiome research in the lung and also the gut, what do you think we should be telling patients in terms of the things they can do to sort of optimize their response to immunotherapy in regards to the microbiome? Obviously there's been some data about antibiotics use and its negative impact, perhaps proton pump inhibitor use and negative impacts. Are there dietary things that patients should be doing? Should we be cautioning them about probiotics? What's sort of your standpoint, Sagan, at the moment in terms of what you tell patients about the microbiome? It's a bit tricky as we don't have really established data, but it's all very promising.
You're right. Actually, the only thing I conclusively tell them is to stop smoking, which we all do, because I think there's enough data to support that. In terms of diet, I think everything you've sort of mentioned, there is data to say not to have it, but I think it's hard with, say, proton pump inhibitors. Someone who's had radiation may have reflux, and so they sort of need it, and how to balance, comorbidities with sort of avoiding the tunnel vision of just looking at the immunotherapy and the cancer rather than the whole patient and the other symptoms, I think is challenging. I haven't actually, to be honest, don't make any specific recommendations at this stage, because I think it's still an evolving space. But happy to take any suggestions from the both of you if there is something I should be telling patients.
What do you think, Mark, as a scientist in this area? Are there things that you're doing or lifestyle changes you've made in relation to what you're sort of learning?
Yeah, sure. So, don't put me in front of a patient because I'm not trained on that front at all. But I really think that what we can say is that there's a lot of hope in the future. So this is what the sort of research we've going at the moment between Sagan and myself, and of course yourself too, Anna, is that we will know more in the future. Yeah, just to hold out the hope, but to listen to the advice and not to listen to misinformation. There is some data to suggest that, of course, antibiotic use can impact immunotherapy, but the clinicians are aware of this now, and where work is ongoing to look at those pre and probiotics or symbiotics and how that may impact therapy in the future. So we don't know enough just yet, so that's why the research is ongoing.
Mark, what's your view on the oral microbiome and then the lung microbiome? Are they connected? I mean, I'm sure they're connected, but how closely related are they?
Yeah, absolutely. So I think, just talking about antibiotics, there's some of the research to say that antibiotic use can lead to the increase of some immunosuppressive T cells that will go to the tumor site to impact immunotherapy, for example. So, of course, the gut microbiome and the microbiome closer to the tumor or the host response to immunotherapy is impacted. I know that there is some clinical trials ongoing at the moment that are looking at implanting various microbiota within the gut. So Anna's talked about FMT, but there's also specific pills that are enriched for specific microbiota. The number of pills that the individual needs to take is quite large, and it needs to be ongoing because we know then the microbiome of an individual will stabilize over time, so it needs to be maintained. The other challenge that we have at the moment is that certainly across the environment, if we're looking across the world that we live in, that the number of species of bacteria, for example, that we can identify is increasing day by day. And a lot of these species that are being identified have never been cultured before. So there's a lot of challenges on that front to increase the abundance of some of these microbiota before we can put them into a pill form and take them. But so the work is ongoing. We're really establishing the evidence at the moment to suggest that taking specific species may improve immunotherapy response.
It's an interesting question, saying that something that I've been really interested in lately is whether or not having a dysbiotic oral flora then leads to a dysbiotic lung flora, because we know this, they're so intimately connected anatomically and also sort of physiologically with microaspiration and other things like that. And I think some of the data we've seen in research to date looking at lung cancer tumorigenesis has sort of focused on the idea that those supraglottic taxa, the anaerobes that you see in the mouth, if they get down into the airways do seem to be associated with lung cancer pathogenesis. Things like Prevotella, Villanella, those sorts of microbial groups do seem to have a negative prognosis on patients with lung cancer. So I think that is an interesting space, is that how does the oral microbiota influence the lung microbiota, and can we change that? It's just also made me wonder about dentition and things like that, which I guess smoking is one thing that definitely results in poor dentition. And you just wonder about advice along that front and whether we discover something interesting there. But yeah, I think there must be a link between the oral flora and the way in which it interacts with the lung microbiota and how that affects treatment response. I think that is a very interesting area that we'll probably tease out more as we get more data. So I guess finally, before we wrap the podcast up, is there any interesting updates that either of you have from the research that you've done to date? Any progress reports? Or are we still sort of in the very early days of getting data and collecting samples?
Yeah, very early. We've managed to get a couple of samples, so still very early. Yeah.
Yeah, also here, very early.
That's good to know, Mark. Good to know.
Yeah. But what is quite exciting is that we're really keen to profile not just the microbiome in these lavage fluids, for example, but actually look at some of the immune cells that may be interacting with the microbiome. So that's a new collaboration that we've commenced, and hope to update everyone in the coming year or two.
Excellent. No, I think it's such an exciting space, and I think we'll just hear more and more big conferences and in discussions like this. I think it's exciting to be at the forefront, but I look forward to hearing more from you and other collaborators about what we're discovering. That brings us to the end of this episode of the podcast. So thank you, Mark. Thank you, Sagun, very much for the discussion and all the interesting insights that you have. Thank you, guys.
Thank you very much.
Thanks, everyone.
And thank you to everyone listening to Toga's Conversations in Lung Cancer Research. If you've enjoyed our show, please make sure you rate and review us on Apple Podcasts or Spotify so that we can keep making more and more interesting discussions.